Hi, it's Beth Wright. I'm providing you a podcast for NUR 136, Unit 2, Chapter 4, and this is dealing with our infant and pediatric population of patients. So I wanted to put this slide up for you because we see kids who have chronic illnesses. There's numerous chronic illnesses out there. Diabetes, asthma, numerous ones. And so I just wanted to put this up just to speak a minute about what we're dealing with when we're talking about our pediatric population. And we definitely have to think about what the child's developmental stage is, not necessarily their chronological age, because sometimes we see with illnesses that pediatric patients will digress. And, so we need to definitely assess that developmental age when we're dealing with pediatric patients. We want to have as much independence with those children, with the children as we can, that can help them deal with their chronic condition. We want to always promote, maintain, and restore health, if at all possible. We definitely need that family-centered care. We have to assess what the family needs are, what their responses to the illness are, involve the family in the care, such as diabetes. The whole family has to learn about diet control and how to care for that child. And we need to assist the family into promoting that maximum growth and development. Likewise, we need to be supportive of the family because it's a lot of times very difficult for families when they're dealing with chronic illnesses. So we need to be that support person for that family. If the child has to be hospitalized, then we need to determine how the child is cared for at home so we can continue routines. So routines for children can be comfort to them. So we want to try to continue that in the hospital setting if at all possible. And also respect families' expertise in the care of a child. They are the ones that are dealing with the child the most. They can tell you what works and what doesn't work, and we need to listen to that. And we can also encourage care conferences for planning care, and again encourage that independence and self-care of the child. So we know that children differ from adults, and because they have an immature system when they're starting out as neonates, then we have to think about how drugs bind and to the different parts in the body, how the receptor formation is going to react, because many times those receptors are immature. So there's definitely some things that we got to consider when we're talking about the pediatric population. And when we're talking about our pharmacokinetics, our absorption, distribution, and metabolism and excretion is definitely going to be affected. So when we talk about pediatrics, here are the ages that you need to utilize. This is what the NCLEX, the state board exam that you take after you finish your schooling. This is how they determine or define the ages, and this is our farm book as well. So premature, we're talking about premature infants, is any child that is born 38 weeks or 38 weeks with pregnancy. In other words, the mother is 38 weeks, or that should be less. So anyway, 38 weeks. And then a newborn and a neonate is 0 to 4 weeks of age, And then an infant is 1 month to 1 year, and a toddler is 2 to 3, preschool is 4 to 5, school age is 6 to 12, and an adolescent is 13 to 18 years. Okay, the calculations for drug dosage calculation for pediatrics, what is used is the weight, and the weight is converted from pounds to kilograms. And so what you'll see with medications, if you look up any given medication, it'll give you a specific amount of milligrams per kilogram per 24-hour period. Okay, and that's usually how you'll see that defined when you look up specific medications and dealing with dosages. So we need to know that so that, we don't give a pediatric patient way too much medicine, because most of the medications, when you look at the dosage of medications, most of them are set for adult dosages. So we got to definitely look up at our pediatric dosages and what is recommended for them. Also, you'll see body surface area used as a way to calculate dosages for pediatrics. So our body surface area is involving the weights in kilograms and the height in centimeters. And then the pediatric dose is going to equal to the body surface area by 1.73 times that adult dose. So our pharmacodynamics involves drug actions on targeted cells and alteration in cell reaction and function. And we got to think about with pediatrics that they have an immature body system. Their body composition is definitely going to be different than an adult. What is their genetic makeup, and then their total body water, because the smaller they are, the more body water they have. What are their fat stores, and how much protein they have. So just a basic true and false question. The basis of pediatric drug dosing is weight. Okay, so that was the Jeopardy song, and hopefully you answered true. So the basis of pediatric drug dosing is weight, and we determining the drug dosage is highly dependent on the growth and development changes that occur with a child, and the prescriber uses weight to calculate pediatric doses in an expression such as gentamicin, which is an antibiotic. Gentamicin, 5 milligrams per kilograms per a 24-hour period. Or we also use body surface area, which also uses weight and height. So let's talk pharmacokinetics in pediatrics. We know that absorption is going to be an issue. With the younger the child, the more of an issue. And generally speaking, you could say that most everything, give or take a few items, is pretty much at an adult level of functioning at around age 2. So our neonates have a delayed, irregular gastric emptying. In other words, their stomach doesn't empty as fast as an adult. And so when that happens, that means that more medication can be absorbed in there than what should be. They also have reduced gastric acid, and so depending on the type of medicine, if it's acidic, then it's not going to be absorbed as quickly. So we have to kind of think about that. Less acidity means absorption of acidic medicines are less. A decreased blood flow to the skeletal muscles and weak contraction. So that could indicate, if we're given an IM injection, intramuscular injection, if we have less blood flow, then, that might be affected with the absorption. Also, intramuscular injections are, they have the fear factor with pediatric patients. I mean, we've all had shots probably, IM injections, and they hurt. So, yeah, the fear factor is definitely there. I know it is for me. And then there's thin skin, could possibly increase absorption, for that matter. Distribution depends on the total body water. Newborns have more body water, which means drugs that are water soluble are diluted more quickly, and so they actually may need a higher dose, and that would be only certain medicines. Not all medicines are water soluble. Infants have an immature liver function, and that's where our protein is made or developed. And so if our immature liver function causes a low protein level, then that means that's leaving more free drug available, and that can be considered a toxic level if there's more free drug. Now, after the first year, protein binding occurs at an adult level, so that's a good thing. Also with distribution, the blood-brain barrier. Neonates, it's not well formed in neonates, causing the central nervous system to be affected. And so we must check consciousness level and, all the CNS function when we're given medicines that can either depress or excite that central nervous system. Metabolism, our liver enzymes, the cytochrome P450 is not exactly totally developed. It's low in neonates, and so they can't break down drugs that require that enzyme, and so they can become toxic with those particular medicines. So we have to be careful about that. With elimination, because we got immature kidney function, we may have an issue with toxicity as well. If we have a reduced glomerular filtrate rate, then we have a slower renal clearance, meaning that stuff is not clearing out of the kidney at the rate that it would in an adult. So again, they can become toxic with their medications if depending on what they're getting. So we got to be careful about that. Now, medication administration, it talks about in your book that communication and cooperation and adherence is definitely a challenge when we're administering medications to pediatrics, and anybody with kids knows this to be the truth. So when we're at a level of where we can talk with children, we need to communicate with them, and certainly it's always going to require communication with the parents or the guardians. They need encouragement, children need encouragement, and we need to engage them in the whole medication administration and the care aspect so that we can have a positive outcome. So with infants, of course, and all pediatrics, correct dosage is going to be crucial. Safety in administration, it's recommended you use a dropper or syringe, and the buccal area, which is your cheek area inside of your mouth. IM injections, use the smallest needle that can be done, and the preferred location is the vastus lateralis. And rectal suppositories, they can be easier for infants. And IVs, they recommend the scalp, the hands, or the feet. And of course, we're going to educate parents on this. It's traumatic for the child, especially with IVs. It's traumatic with the child, and we do have to restrain them to get an IV started. It's traumatic for the parents to see that. So we try to get that done as quickly as possible, and using safe measures and using our techniques that we use. Toddlers and preschoolers, consider once again, and always the growth and development with the children. You got to involve them with medication administration, have them hold items, or choose a bandage or something that they can be engaged in some way. The toddlers are more curious, and preschoolers are inquisitive and controlling, but they have a short attention span. So explanations should be short and simple, and adults need to control administration, which is easier said than done sometimes. Medication administration with oral, if possible. Mix it with something. IM injections, as they develop, we can move to the ventral gluteal area. And with IVs, the scalp still can be used, and the older children, the hands are the antecubital area. School-age children, explain medications more in detail. They can take them independently, but they still need that supervision. And of course, we want to educate on safe practice. Chewable tablets work well. Monitor for any kind of abuse. Teaching opportunities are fantastic here with children. Most children want to learn more, and so teaching can be a great opportunity for us, except we have to teach on their level. Weight loss methods, alcohol and tobacco use, acne, antibiotic use, birth control, and sun protection are some of the teaching things that we can work with this population. And then, last but not least, self-care related to medication and administration is a good teaching point for adolescents. True or false? Da, 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 da. And the answer is true. Okay, they do appreciate self-care, education, and are most of the time completely open to that. Okay, that concludes your podcast for this chapter.